And we got to talking about GLP-1 medications like Ozempic and Mounjaro. And he told me something that almost made me drop my cup of coffee. He said, Albert, I do not really understand why there is such an epidemic of prescribing of Ozempic and all these medications. People just need to learn to eat right. Welcome to your daily health briefing. I'm Dr. Albert Tackett. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. I went to a medical conference and I was sitting in the lounge chit-chatting with one of the physicians who was a participant at the conference. And we got to talking about GLP-1 medications like Ozempic and Mounjaro. And he told me something that almost made me drop my cup of coffee. He said, Albert, I do not really understand why there is such an epidemic of prescribing of Ozempic and all these medications. People just need to learn to eat right and exercise more, and they will be fine. Now, in that moment, I almost lost it, but I remembered I was at a medical conference and needed to behave myself. So I gathered myself and promised myself to make an episode out of this encounter. So I brought today my colleague and primary care expert, Dr. Khan, to explain to us why this was a terrible opinion coming from a doctor.
Absolutely.
Because, as we very well know, GLP-1 medications are not a matter of religion. They're a matter of science. Why was that position crazy, Dr.
My
Khan?
God, man. Sometimes you're shocked, right? In my head, I'm thinking, what field was he in, Maybe like pathology or something. He's in the lab all the time, And I certainly completely disagree with that, right? Obesity is absolutely a disease where, when something affects the population in a way that obesity is now affecting the American population, and the amount of associated medical conditions that go along with it, there's no doubt that this is a disease that we need to address, talk about, and then figure out, When I say associated diseases, what I mean is a lot of diabetics that you see, a lot of them will be obese. And a lot of patients who have heart disease, a lot of them will be obese. And a lot of patients who have sleep apnea, a lot of them are obese. And the list keeps going on and on and on, right? It's because as you do gain weight, your body does not function in the same way as it did prior or when you were of normal weight. And again, I could talk about this forever, but a lot of these things started back in right around the 1970s when we started using high fructose corn syrup. And, sometimes I challenge my patients to go find a picture of any American beach, whether on the West Coast, on the East Coast, but a picture of the beach with, people hanging out, having fun, but like prior to 1970. You will not see an obese person in that picture. It did not really exist at the level that it is at now. When you also look at the data from 1970 and the use of high fructose corn syrup, which is an artificial sugar that we put in almost every single drink, the occurrence rate of diabetes, obesity, heart disease, cholesterol issues, everything skyrocketed. Statistically, the chart goes straight up until this day from the 1970s, and now we're in 2026.
So basically what our colleague here was doing was blaming the patient for their disease. Just like telling somebody it's your fault you have high blood pressure. It's your fault you have diabetes.
Yeah, the kids call it gaslighting.
That term.
That's what he was doing, yes.
I've heard of it.
Yeah.
I've been accused of that once, gaslighting. And that's, if you didn't know, go back and watch the Jamila episode of this podcast, which actually is the reason why we have the daily brief.
I love it.
I had an interaction with the patient where I walked away and she said I gaslit her and I had to look up what that means. So tell us, how was that doctor gaslighting patients?
So again, he's saying obesity isn't an issue. It's the patient's fault that they can't control what they're eating and what they're drinking and or not exercising, whatever the case is.
But we are by no means excusing
Right.
people that there is a lifestyle component.
Absolutely.
But what we're saying is that it's more complex
Exactly.
than people just liking to eat a lot.
You can't simplify it to that level, That's just looking at it way too broadly, and that you miss a lot of the details that really matter when you look at it from that perspective.
Okay. Because science shows that there are behavioral factors.
Absolutely.
There are nutritional factors.
Absolutely.
There are psychiatric factors.
Genetic factors.
And genetic factors that are all involved in determining.
Psychology, it goes hand in hand with a lot of this kind of stuff, How many times do we see patients complaining, I stress eat? Or my personal issue I saw when my sister went to medical school. She was a stressor and she was a stress eater too, right? And she said it. She told us, so when she was cramming for those tests and, freaking out as a student, she would eat lots of ice cream as a comfort. And she gained a lot of weight while she was going through her medical school experience, For me, it hits home because that was my loved one. That's my sister. And that made me also realize, to our point, that this is not just, hey, you're making bad decisions. There's a lot more that goes into this, a lot more cause and effect, certain reactions, the psychology of the individual, and so on. So that it's much more complex than that physician sort of made it seem to be.
And another reason why this is even worse coming from a physician is that we play directly into the hands of insurance companies. Many health insurance companies already dismiss the notion of obesity being a chronic condition. And when a doctor says that it's not, it's just the patient having to eat and exercise more, you're just saying, well, I agree with the insurance companies, and you're going against the position of the American Medical Association, the World Health Organization, and other reputable medical societies that obesity is a chronic disease.
No, and my point being, one of the first points I said here, a lot of the obesity we've seen started right after 1970, right? And I'm talking about a cause and effect. Our government, our food industry companies, we started putting in high fructose corn syrup into a lot of food, right? Prior to that, our population was not obese at the level that it is today. Even today, when you compare America's statistics of obesity relatively to the rest of the world, any other developed country, any other place, pick a place, we're by far worse. We by far spend more money on healthcare regarding these issues because, again, like we were saying, obesity is tied to a lot of other chronic issues. We have the worst outcomes. Our food has so many different chemicals, and these chemicals have been banned in hundreds of other countries to the point where if you buy a bag of Doritos from, say, Toronto, or you're in Cancun having a good time, you buy whatever kind of American snack, those countries have different regulations, and you bring that wrapper back with you, you'll see the ingredients are different. The food dyes are different, and let alone the rest of the world, these chemicals have been banned for decades. And there's a very clear distinction between the numbers that we're seeing here, and they don't really exist at the level they do in the US and a lot of these other countries. So that really tells you a lot,
So thank you for that explanation, Dr. Ken. I think this warrants a separate episode on corn syrup and
that's a good idea.
The origins of obesity in America.
I like that, yes.
That episode is coming.
Yes.
So basically what we can say here is that we as doctors have to be at the forefront of advocating for patients, telling both patients, the healthcare industry, the healthcare insurance companies, that obesity is a disease, and we are going to fight for patients and put everything at our disposal, the psychiatric care they need, the medications they need, the exercise they need to help patients fight obesity.
Absolutely. Obesity, even, you take away the serious, like the heart disease and the strokes and the diabetes, all of that, take that away. We're not even going to talk about that for a second, but just look at how this disease affects you on your day-to-day. Number one, your mental health. As you gain weight, very commonly people, when they look at themselves in the mirror, they don't like it. Their self-esteem suffers.
There's some studies that show obesity
and depression
raises the rise of 2 to 3 times the
more
risk
likely
of depression.
Yeah, exactly. And I don't doubt it. Now you're talking about mental health issue that comes from that. You can even not just depression, but anxiety about the way you look when you go out or you're wearing certain clothes or what. That's another thing that can affect, right? Then take another step back. What about your day-to-day? As doctors, we refer to it as ADLs, activities of daily living, right? What are you capable of doing or what do you do on a regular basis? Your day-to-day stuff sort of will get affected by obesity, meaning You go up the stairs, you're short of breath and you're huffing and puffing, or you can't walk because you have knee pain all the time because, your body's not designed to hold up all that weight, Historically, biologically, evolutionarily, look at it from any perspective, the human body was not designed to be holding up 200, 300, 400 pounds at all times. So now you run into knee problems and knee pain and arthritis in your feet or plantar fasciitis in your foot, and this stuff affects you on a day-to-day. Just your basic moving around is painful. So you move around less. It's harder to work, right? All these things then have other consequences. Even if you don't look at those heart disease and all those statistics that we talk about and we always tell patients about, just your day-to-day gets affected by it, So how can it not be a disease? And then you look at the amount of people suffering, about 45%, you're talking about 200 million people.
As we wrap up, Dr. Khan, what action items do we want patients to take away from this if they have a doctor who says the same stuff that this guy I met at the conference said?
Absolutely. So, what you have to realize is, yes, diet and exercise are big components in this. Absolutely.
That's number one.
You're right. I'm not denying that whatsoever. But at the same time, it is a lot more complex. There's a lot of other genetic factors, mental health factors that go into weight gain, and environmental factors as well. Sometimes, you don't know how to cook and the only access to food you have is the cheaper options, which is fast food,
Food deserts.
Exactly. And so what can you do if you can't afford the higher quality, quote unquote, food, and you have to make decisions for your family, right? So these kinds of things, financial stuff as well, right? So it can affect you in so many different ways. Obesity is a disease. If you believe you're overweight, talk to your doctor about it. Look at what options you have. Look to see, hey, look, am I having other associated issues that go along with obesity? Then one step at a time, talk to your doctor and take it from there.
And we doctors have to learn to be better patient allies.
I can guarantee he was not a primary care doctor.
Turns out he is.
Oh, no way!
Unfortunately, he is.
That hurts.
And that hurt even more.
No.
So on behalf of all patients, if you've been given this type of advice by a doctor that they don't believe in GLP-1 medications, on behalf of the medical community, we apologize to you.
Absolutely.
Okay? That was wrong. You deserve better. You deserve evidence-based treatments, and GLP-1 medications are part of the armamentarium that we have to treat you.
Absolutely.
Thank you for your time, Dr.
My pleasure.
Khan.
Thank you for having me.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Taken, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.